few months ago I did, or yeah, I just don't feel like going on anymore. You put yes, and the rest of the screen opens up. Well, what are you thinking? Suicidal thoughts. Have you got a plan? Well, yeah, I gave my dog away to my neighbor next door because I didn't want him to be without somebody to take care of him, and I've got a guy. They start going into a plan. Ooh, that's serious. How often do you think about it? It's all day now. The past week or so, I just think about it all the time, those intrusive thoughts. So you see, that is a full screen. But that first question opens up that door to find out more, instead of me just a bunch of all of us subjectively looking at the same patient could handle it differently. So all patients now have to be screened for suicide. So you screen for suicide, and with a depressive disorder, just know that that's a risk with these patients. Help identify their coping strategies. That's real important. If somebody can tell you that they cope with it, the feelings that they've had, the depressive mood they've been in, you know, I take my medications, I try to keep exercising even though I'm down, you know, I can tell it's coming on, and I don't call into work, you know, I try to get up. They've got some coping mechanisms. They're still working. They're still effective coping mechanisms. You want to support activities that increase their socialization. Well, you've been here a couple of days, you've been in your room your whole time, we really need you to get out and come eat lunch with everybody at the table. Support them in trying to socialize. Teach them about the disorder. You know, I know you're having a lot of bad thoughts about yourself. Remember we said self-deprecating behaviors, and I know you've got a lot of negative self-talk going on. But today we're going to talk a little bit about the disorder and where these thoughts come from and all, and help them understand the disease. On the mental health unit, the RNs are responsible for coming up with what topics they're going to teach every day. So you can see, they may not know, they may have clients with all sorts of disorders, but they may pick one type of disease that they may teach about just to help people understand what's going on. And then tomorrow they may teach about something else. Engage in a therapeutic alliance. I'm going to work together with you. We have an agreement to work together. Keeping your promises, building some trust with this person. Support their progress towards their goals. Collaborate with the treatment team, really important. The treatment team, hopefully you'll be able to see it in your clinicals. It's the best, like I said, best example of interdisciplinary care I've almost ever seen, because you have everybody in there. The doctor, the therapist, the social worker, the nurses, the techs, the dietitian, and you want to collaborate with that team and tell them what you've been seeing going on with the patient, so you can all kind of track the progress the client is making. They could go in the room with the provider, the doctor, to get their medications adjusted and tell the doctor everything's going great. I slept all last night, I'm eating better, I'm ready to go home. That's why you have the interdisciplinary team. Well, Leslie, how has he been doing on the floor? He hadn't slept since he's been here. You know, I talked to night shift at report this morning, and he still didn't sleep last night. You know, so that interdisciplinary team is key, because you're watching how they're doing. Help identify symptoms of anxiety. So often with depression, anxiety is a part of it. So you want to see how anxious they feel. And as they're progressively moving along, just the nature of the disorder helps them minimize successes that they've had. So the RN is a good person to say, well, now remember last week you said you couldn't do this, but do you remember Saturday? It was a great day. Look at what you did, you know, and help them recall their successes so that they're not just constantly beating themselves up. So that is the end of that slide. Let me look at my notes and see those. Look a little more at my folder. these few slides come from a book talking about just the differences in the swings with bipolar and just how good the manic phase feels. I'm not going to go over this one because we've covered it all. Yeah, we've covered all that. And tomorrow we'll recap a little before we move on to everything else like we did before to make sure we sit on everything. Okay, grief and loss is in the mood section because grief obviously affects our mood. It's important to remember there's a lot of different type of losses. It's not just necessarily the death of somebody. That can be a loss to someone and that someone can have grief over. So real important to remember this when you're working as a nurse. Of course, the most obvious and most significant loss is the death of a loved one. But people can also grieve the loss of like their self-esteem, their identity, dignity. I have a friend, and I talked to her on Facebook the other day, and she knows I share this story. She was one of our nurses in New Orleans, and she got septic. Not quite sure what it was from, maybe an IUD or something. She had an 8-week-old baby and 2 other kids. She got septic and came into the emergency room. They saw her and gave her some antibiotics. She went home and got so sick she couldn't walk out to the car, so her husband had to carry her, brought her back in, and she ended up in a coma. And they had her on so many pressor meds, try to keep her blood pressure up. When she was in ICU, she ended up losing both her legs, her left hand, and her right hand down to her first knuckle. She was 29. And then she miraculously lived. I mean, we were in with the priest when they gave her last rites. So she lives, and she's a real fighter. She has the prosthesis on both legs. I mean, she went right into therapy and got prosthesis on both legs. She sells LuLaRoe, that brand new clothes. She didn't go back to work in the hospital. And she's like done spokesperson work for the brand, you know, because she's such a success story. She's really been good at it. But she even posted something the other day that she woke up grieving her legs, you know, and she and I even talked. She said the guilt that she would feel for grieving her body image. She said, how awful is it? I've got 3 little kids, and I'm laying here in the bed mad that I don't have my legs. You know, but she had to go through that process to grieve the loss of her overall body image, and most specific, her independence, you know, and so she posted something on Facebook the other day, and I told her, I said, I share your story so often. But her daughter, that was the 8-week-old, and she got septic, is now getting on up there, and she said, I was laying in bed feeling bad that I didn't have legs. And she said, and then up walks my daughter with my fake legs, said, Mom, put your leg on, you know, we got to go somewhere. And she's like, and I just thought to myself, you know, how awful. So you see what she's struggling with, a lot of the guilt, and I shouldn't feel this bad, but she had to work through that, and she still has to work through that. It was such a loss for her. And, you know, we were all just really aware of it. As soon as she came out of the coma and started talking, we were all like, this is going to be real hard for her to move through this loss and the guilt. So, you know, change of locale job loss for some people is a huge loss that they have to grieve. So just always be cognizant of what your patient might be going through. And what may be a really bad loss to me may not be something, maybe something really significant in someone else's life. Sorry. Responses to loss can be physical, cognitive, behavioral, and affective. And that's the same with depression, too. They think that some of the neurologic, the fact that you have neurons and all in your brain and throughout different parts of your body maybe why you get physical symptoms when you're depressed, that you may hurt when you're depressed. And I will tell you, a certain level of grief makes you physically sick. You know, the grief can just be so overwhelming that you have almost like flu-like symptoms. And so the responses to loss can be a physical response, feeling physically sick. Cognitive thought processes can change. Behavioral, the way you act, the way you get along with people, and then your affect, your mood, how you come across. So wide-ranging impact. So what are those physical manifestations? Weakness, anorexia, the true anorexia, not wanting to eat. Feelings of choking, shortness of breath, tightness in the chest. You'll have people sometimes that the grief is so severe they end up going to the hospital just to get worked up for an MI because they can't tell if something's really going on, or are they just that upset over the grief. GI disturbances, of course, sleep disturbances, and increased vulnerability. Not able to be not your normal self. So the thoughts that are going on, the cognitive manifestations of grief, preoccupation with the deceased. If it was a loss of a loved one, just preoccupied with that person, talking a lot about that person. So if you're around someone who's grieving, they're going to need to, it helps for them to talk about it because they're probably preoccupied with this person. Difficulty concentrating. Goes without saying. A longing and a sadness, you know, longing to want to see that person, and they could actually even have hallucinations, things that are not there. So behavioral things, what you see with grief. Disruption in their normal patterns of behavior. It may be to the point where their activities that they live in are interrupted, where they might have been the normal person that showered and washed their hair every day, those sort of things. Those patterns are not the same. Inability to they might have been a really organized person before and are able to stay on task and all, but now they're more disorganized, inability to keep on track, disorganized thoughts. They may be distracted when you're trying to talk to them and just keep kind of jumping from one thing to the other. And things that were important to them before the loss may not be important at all. A change in what was important to them. And then their affect, anywhere from sadness and guilt, loneliness, anger, just run the gamut in emotional affect. So what are some definitions? Grief is an internal emotional reaction to loss. Bereavement is the state of grieving. And mourning are the actions and the expressions of grief. And kind of with grief, the approach to how healthcare professionals deal with grief has changed. Again, you know, used to they always just strictly taught us the stages of grief and that people move through these stages of grief and then they're better. Well, the whole approach now is a little bit different, and we understand that they may go through the patterns of grief and then backtrack and do them again. Everybody is different in how they deal with the grief. And there used to be a hesitancy to ever call grief depression and diagnose somebody with depression because they didn't want to stigmatize people. So there was a hesitancy to even kind of have any crossover. Oh, they're just grieving, they're not depressed. It's just, you know, she's just sad. She's not got a problem like depression. But now you will see a quicker move to go ahead, and if you think it's depression, go ahead and screening, working them up for depression, and if they need something for the depression, go ahead and treating it earlier than not, like within about 2 months, instead of just ignoring it until someone is just in a snip. But you still categorize grief. Anticipatory grief, I don't know, you may have seen this with people too, especially with someone with a chronic illness in their family, and they're already anticipating the loss of that family member before they die, but they know they're going to die. So you will see them start moving through some of the grief process, and some of this disorganized thinking, sadness, changes in their normal pattern may happen, especially with a child. You know, they have like a child with a cancer diagnosis. You'll see their parents moving through anticipatory grief. Another friend, and again, she probably wouldn't even mind if I shared her name, but her son, she lost her son to DIPG, that brain cancer. And when they went to St. Jude's with him, that first visit, they automatically put the parents into counseling. So they saw counselors as part of the thing.
It's similar to like my brother's story. I got married on his birthday, and last year when I talked to him, he asked me how my anniversary was. I was like, great. And how was your birthday? And this is the grief. I couldn't enjoy it because I didn't know if it's going to be my last.
Forgive yourself. Yeah.
And unfortunately it was. So.
Well, you will see people go ahead and this disorganized thinking, this sadness, and all. Of course, they're going through it already. They know this person is going to be experiencing it. Acute grief is a painful experience. You know, it happened. You didn't get to plan ahead. It was acute. We came on. Then dysfunctional grief. This is what you used to always hear instead of the depression, but dysfunctional grief, usually you see it associated where the death was traumatic, unplanned, and then the person's not moving along in a normal pattern with the grief. It's complicated with all sorts of other problems. It's lasting for a chronic period of time. It's 2 years later, and they're still grieving, and these issues going on with grief are still happening to them. So the best way to categorize it is dysfunctional grief. And then there's chronic sorrow. And I kind of think, and the book talks about it too, chronic sorrow, my grandmother was 96, and sorry, it's Dr. Scott. And it sure was sad. I hated to see her die. And I grieved her. And it took a while, and it was really sad. But then I'm over it. I don't have chronic sorrow over that. She had a long life. I'm able to digest it all and think through it normally. But I think with like the loss of a child, or maybe even the loss of a significant other that was like your life partner, it's just not realistic to think that you're going to get over that feeling. You're going to have sorrow over that life chronically. Because we talk about sometimes, especially like in L&D and things, if you had a child and you sent your child to summer camp, you're going to miss them after a week. But if they stayed at summer camp for 2 years, you're not going to be like, oh, I don't miss them anymore. You're going to miss them more. So it's almost like the loss of a child just kind of compiles upon itself. You can't expect that to all of a sudden be like, oh, I'm better now. You'll deal with chronic sorrow. So one thing that we didn't talk a lot about with the stages of grief, and we didn't talk about it a lot in depression, was numbing and blunting of your emotions. And sometimes with depression and other things like grief, you will talk about blunting of emotions. That's when you just don't see the full range of emotion, the blunted. So at first, they kind of avoid the whole loss. They may be in denial. You'll hear people say, I just can't believe it really happened. You know, if he hadn't have gone, you know, if they hadn't been driving that day, they wouldn't have had the car wreck. They kind of have to ruminate over it because it just shouldn't have happened, so they're kind of in that denial phase. But then they'll confront it, and they move through the confrontation stage of grief, and that's active mourning. They may be disorganized, they're in despair, they're aware that they've lost this person. But then you will see them move back into the reestablishment stage, trying to get back to their normal, and it's a gradual process. They have to reorganize themselves, especially if it was a significant loss, and they would start to go through the recovery. And this just goes through, again, we've already pretty much discussed it, the things they may feel during the grief. The task of grief, and you will deal with this with families, or in your family, they'll tell the story over and over again. These are just tasks. These are things that people feel like they have to do with grief, and so they'll tell the story of what happened, expressing their sadness, talking about any guilt they feel, anger. They'll go back over their relationship with them, that, you know, we were just so close. This was we met in high school. They'll go back over the relationship with the person. They'll start to explore life after the loss of the person. I'm not sure what I'm going to do. They'll start talking about their plans. And they're going to need to they have the task of needing to feel like they are accepted by other people, and they need to know that other people understand. Complicating factors. Pain of great intensity, so you'll see like self-medicating, or even, you know, thoughts of dying, anything to relieve the pain. And like we say, a lot of times when people talk about suicide, again, it's not that I want to die, I want to kill myself, it's I want to get away from this pain. It's so bad. Some people, depends on their culture, it may not be okay to express these feelings, and we already talked about part of the task is talking about it and talking your way through it, the normal process of grieving. But some cultures expect people to keep things inside and not discuss it, so that could complicate someone's grief. They may need to talk, but their cultural group doesn't accept it. There's also a lot of anxiety, a lot of fear of losing control that can complicate their grief. Some of the things that we can do as nurses, prevention before the loss, family involvement in the community, improved parenting. When loss is impending, help them. Maybe go ahead and suggest some grief therapy. Needs of the dying patient. We always say it's really hard for nurses to realize, and doctors to realize when a patient is going from we're trying to take care of them and get them better to where they're actively dying. I'll never forget, my grandmother literally looked at me and said, shook the washcloth off her face and said, you know I'm going to die today. That was just my grandma, and I was like, yeah. And I really did. She looked really different. She had CHF. She had a total different look to her. She was the 96-year-old, and I was her only grandchild, so we were super close. And she said, well, you know I'm going to die today. I said, yeah, I kind of thought so. And she said, don't tell your mother. I'm like, oh, I think she's going to find out. But the needs of the dying patient. She and I are in here having this conversation. We go ahead and flew some family in. She planned her funeral. It was perfect for her and I that it went that way. You know, it couldn't have gone any better. And she told me what she wanted to do, and I told Mom and Dad what we were going to do. And I remember, and the nurses on the floor were real attached to her. And she was a real private person, and it was like, I'm not gonna clean her up on the bedpan. That was just not what she wanted me to do. And I can remember hearing one of the nurses saying something about, and her granddaughter's a nurse. They were mad that I didn't clean her up. And then they came in at one point and said, she really needs her breathing treatment. She looked at me and was like, and I said, we're not gonna do it. And and we heard him kind of mumbling later. It's almost like they thought we were trying to just speed it up. You know, we were trying to kill grandma by not giving her the breathing
Following
treatment.
what she wanted you to do.
It was her autonomy and her decisions. And I mean, the cardiologist was already like, whatever y'all want to do, you know, the rest of the day. So just never forget that every family is different and the patients have their own needs. You know, and as long as they're not really trying to kill grandma. But the dying patient has unique needs, and it depends on that person. And it is going to be real hard for you as a nurse, and some of y'all already work in the hospitals or work in healthcare, so you know that. But always don't forget to be assessing what the family and what that patient needs, and it's not about you always. As long as the patient's being taken care of. Something bad didn't happen. Explain the patient's condition and treatment. Teach self-care and promoting self-esteem as long as they can. Teach family members to assist in the care where it's appropriate. Because it was like, grandma would be like, we ain't doing that. But if we'd have been home or something, I might have been, but she didn't want me to do that. And meet the needs of the family and the dying patient. In the hospital, care of the body, it depends on where you work, what you will have to do. Some hospitals or some places, the funeral home will come get the body on the floor. Sometimes you'll have to take the body to the morgue in the hospital or where you keep it. Identification then is just as important as it is any time. Imagine the bad day it was when you sent the body to the funeral home without a tag, and you sent two people, so ID and respect, taking care of the body. Like in labor and delivery, we don't put a time limit on how long someone can keep the baby. And one time I had a supervisor call and say, when are you getting this baby down to the ward? Well, as soon as mom and dad are finished holding the baby. It's the only time they're going to see their baby. So it's very, very personal. They actually make little beds now for L&D that are cool. They're cooling beds, but it keeps the baby from not, the breakdown and stuff from not happening quite as fast. And so if the baby does, if they want to keep the baby in the room for a lot longer, it will look normal for longer. And you know, death is just something we are all going to have to deal with, but you're the lifeline a lot of times to that family for teaching and explaining what may happen next and helping them understand what's happening at the time. You're going to have to review organ donation arrangements, if any, and a lot of it, whatever education goes along with that, the timing of this procedure, labeling the body, death certificate issued and signed. But again, it's just very personal, and you've got to check your own emotions before you start caring for these clients. And we will be about finished. This is going to be it. If it's a sudden death, if you're working on the floor and someone codes and you weren't planning on it, one of the main things for a nurse is get the family somewhere situated and get somebody with them. You need to be in the room with the code, but somebody needs to be with the family. If you know the patient's going to die, you want to go ahead and make your plans on how we're going to do this. Do you want, who's going to be in here? Who's going to stay? Do you want to come in after they've died? Do you want to stay with them? Do you want to help take care of them after they pass away? So a lot of questions. It is appropriate. I've gone patients' funerals. It just depends on your relationship with the family. but you can do that, and it is appropriate. Pretty much repeating. I will, like I did last week, we will kind of wrap up since it's a lot in a couple of days. We'll go back over it. You can study all this content today when we're doing the lab after lunch. Any questions? I'll go ahead and let y'all go. Good. See y'all back.